Hello, everyone. My name is Hamed Ektiari, Department of Psychiatry, University of Minnesota, and I'm delighted to be in this talk series. Let me share my screen. Okay. First of all, I put my slides in a Dropbox folder, and with this QR code, you have access to my slides. So you can just scan the QR code, and you will have access to the slides. I don't have any conflict of interest, but discussing about a cross-section between substance use disorder and mood anxiety disorders, specifically major depressive disorder, we can discuss about epidemiology, how they are frequent to be together, what are the clinical presentations that we have, and how we can differentiate these two disorders from each other. How can we treat substance use disorder in people who have mood anxiety disorders, and how we can treat mood anxiety disorder in people who have substance use disorder. So these are some of the challenges that we have in the field. And then how much our understanding about brain and these two disorders could help us to develop more specified treatments for people who are suffering from these disorders. And then discussing about the next steps in the process of treatment. So these are going to be the topics that I'm going to cover in this talk. In terms of the epidemiology, when we talk about how these two disorders, and mainly talking about major depressive disorder and substance disorder, could be co-occurring to each other, we know that people with MDD, on average, we have something like 25% of substance use disorder among this specific population across the world in kind of a large systematic review that people have done. And that was something like 20% alcohol use and 11% illicit drug use disorder and something like 11% cannabis use disorder. As you can imagine, these things could be overlapping. In general, something like between 25% to up to 50% based on different studies, we have frequency or kind of the prevalence of having substance use disorder among people who are suffering from MDD. In the US-based kind of national surveys, the last one that happened, something like it has been published something like less than a year ago, they showed that people who have substance use disorder, around half of them, they have a type of mental health disorder, any sort of mental health disorder. Something like half of this is about depression. So when we talk about any mental illness, we are talking about something like mainly mood anxiety disorder. We know there are some other mental illnesses that could be happening as well, but something like half of them would be major depressive disorder. And then when we talk about people who have any sort of mental illness across the US, something like 1/3 of them, they have substance use disorder as well. I mean, that is consistent with the previous data that I showed you. So when we talk about these disorders, we are talking about a significant level of overlap. Something like 20%, 30%, 40% overlap, up to 50% overlap, which is really significant in terms of the clinical process and decision making. And when we talk about these two disorders, we know that they are really hard to differentiate, because when we have acute intoxication with different substances, they could present as sort of mania or hypomania, or even kind of psychosis type of presentations. And then when we talk about chronic use of stimulants, we know that chronic use of stimulants could make presentations close to what we have in mood anxiety disorders, like decrease in appetite, changes in sleep, even having paranoia. Or when we talk about CNS depressant as substance use disorder, we also have issues regarding anhedonia, lack of sleep. So all those things that could be also presentations of mood anxiety disorder. Also, during acute withdrawal, we have presentations of mood anxiety disorder among substance disorders. And also, even we have what we call chronic withdrawal. People who, even kind of after a period of abstinence, they still feel that they are anhedonic and they cannot enjoy normal life. So we know that these things are quite overlapping. And then discussing about how to treat substance use disorder among people with MDD, or how to treat MDD among people with substance use disorder. Just some kind of basic rules that we have. First of all, we know that people with MDD, people with substance use disorder, MDD is undertreated among that specific population. Also, we know that people who have MDD and also have substance disorder, they have poor prognosis. We know that suicide rate is higher, and the response to treatment is lower among people who have substance use disorder. So we know that the treatment is basically challenging. But as a general rule, when we have a patient with MDD who has also substance use disorder, we usually go with the basic rules that we have for MDD treatment. Especially after a period of abstinence, we can start with SSRIs and then TCA. These are the medications that we can use for people with substance use disorder as well when they have MDD diagnosis. And then there is a question in terms of whether kind of MDD treatment or depression treatment during substance use disorder could be helpful for managing drug craving and improve treatment outcome in substance use disorder. Based on the level of evidence that we already have, we can say that probably this is only for nicotine use disorder we have enough evidence that treatment with antidepressants could basically improve the outcome of things like craving and other things. So we know that bupropion and nortriptyline, which are antidepressant medications, they could contribute to the treatment of nicotine use disorder as well. But how treatment of substance use disorder could be informed based on whether the patient has MDD or not, and could we select different treatment medication based on the kind of the mood anxiety disorder background among the people with substance disorder. And this is another challenging issue and understudied area. And that is kind of one of the challenges that we have in psychiatry. We know that people have complex interactions. And based on the new sort of movements that we have in NIMH, discussing about how we can kind of dig into the overlaps in terms of the genetic background, brain activities, physiology, behavioral processes, life experiences in people with kind of different psychiatric disorder, including major depressive disorder and substance use disorder, and finding the overlaps between these two sides, and trying to use those sort of pieces of information in the process of treatment selection in a framework that we call RDoC framework. In this kind of framework, which I'm really hopeful that would give us a better idea about how we can process a treatment for people with substance use disorder and MDD, and try to differentiate or kind of find the best treatment. At least we have 5 major systems in the brain that are involved in the decision-making process for treatment selection. 2 major systems are basically negative valence system and positive valence system, the first 2 ones that you can see in the slide. And people started to basically develop similar sort of models, specifically for alcohol and addiction. It's called AARDoC. As you can see here, negative emotionality and incentive salience, these 2 parts in terms of whether I feel good or I feel bad, these 2 major dimensions and how these things are being processed inside the brain are considered as important kind of components of how we understand pathophysiology of these disorders. There are other more complex models that people develop. For example, NIDA recently developed another model, but even in those models, you can see that you still have that blue and red colors, those positive and negative valence processes. And the question is how that positive and negative valence and how the kind of differentiations that we have between these domains could help us to select treatment process and kind of develop specific treatment for people. And we have 2 champions in the field, and I should kind of introduce them, Katie Witkiewicz and Karl Mann in Germany and the US, who have done with a group of people, they have done a really nice job in terms of bringing up an idea of, specifically in alcohol use disorder, differentiating people in 2 groups of reward drinkers and relief drinkers. And reward drinkers who have more kind of involvement of the positive valence system, and relief drinkers who have more involvement from their negative valence processes. And over the time, with different fMRI studies, people realized that in reward drinkers, we have mainly involvement of ventral striatum in interaction with prefrontal cortex and more sort of impulsive behaviors. while in people with kind of relief drinking, they have mainly involvement of dorsal striatum interaction with kind of middle cingulate gyrus and also cerebellum, and they are more sort of habitual compulsive behaviors. To be able to kind of differentiate people, there are different instruments, including inventory of drinking situations. And these two items, these two examples, item 2 and item 5, they can show you basically reward drinkers versus relief drinkers. The question is, I mean, can we kind of inform these sort of, use these phenomics that we have for treatment selection? And over the time, people realize that probably relief drinkers are responding better to acamprosate, and reward drinkers are responding better to naltrexone. And over the time, and the secondary analysis on different trials, there are more and more kind of strong evidence for supporting the idea, especially for reward drinkers, that are more responsive to naltrexone, and relief drinkers who are responder to acamprosate, which is quite interesting. Just to wrap up, just giving you an idea about what we have for naltrexone. We know that for naltrexone, we have both oral naltrexone, also long-acting injectable. And the selection between these two in the clinical practice, in my practice, we usually kind of based on the patient preference. Which one do they prefer? Do they prefer to have an injection every month, or having an oral kind of oral form of the medication? But there are some other factors involved in this decision process. First of all, the adherence. And also we know, I mean, when we talk about kind of long-acting injectables, we usually like to start with the oral medication for a while, making sure that the patient could tolerate that, and then go for long-acting injectables. So there are always kind of a discussion about that. But then we talk about, when we kind of prescribe long-acting injectable, we have 380 milligram every 4 weeks in the gluteal. Usually kind of injecting the gluteal kind of area. And as you can imagine, there are some side effects like kind of nausea, which is pretty common, fatigue, something like 20% kind of decrease in appetite, which is quite interesting. And we usually kind of do LFT within the next few weeks of starting the medication. Also, we kind of follow that every 6 months. Over the time, we realized that probably the major kind of contributor to the LFT is the effect of alcohol on the liver, not really naltrexone, but that is something that we usually do in the clinical practice. But for oral naltrexone, we usually do something like 50 milligram per day, monitor for side effects. In some kind of practices, people prefer to start with the kind of lower dose, 25 milligram, and there are trials with 100 milligram as well. So we can kind of play between this range for oral naltrexone. There is one type of sort of application for oral naltrexone, especially among younger population, that they use it as something like a PRN or as needed. So when they feel that they have craving or when they are going to party, they use it to just kind of reduce the risk of intoxication. And that could be a potential kind of entrance level for those who are interested to have that medication. Side effects, nausea, headache, dizziness, as you can imagine. And over time, the level of tolerance is reasonable, so people can tolerate that pretty easily. For acamprosate, we know that it's a kind of a glutamatergic mechanism involved in kind of the effect of acamprosate. This is contraindicated in those who have severe renal issues, and we usually kind of have 664 milligram 3 times per day, which is, I mean, the compliance and adherence might be a little bit lower because of the kind of 3 times per day application. Because side effects like diarrhea, nervousness, fatigue, and it is pretty kind of liver safe. So those who have liver issues, because it's basically excreted from renal pathway, so we are not that much concerned about kidney issues. But when we talk about these issues in terms of the positive valence and negative valence, or reward drinker and relief drinkers, it's also important to consider that in the patient education, or even in the process of different sort of psychosocial interventions that we do for the treatment of mood anxiety disorder among people with substance use disorder. We recently developed a package for psychoeducation of people with substance use disorder, discussing about the the main brain areas that are involved in substance use disorder and how they can have strategies to manage those problems. And we always consider feeling good, feeling bad as two major issues to discuss about in different sort of psychosocial interventions, and also providing specific strategies that we have in behavioral activation interventions to provide them with resources to be able to recover from the chronic anhedonia that these people usually kind of experience, also mood anxiety disorders that they experience. We developed also feminine version of these cartoons to be able to connect with people, even with different kind of racial backgrounds. So we are extending those cartoons. With this QR code, you can find the kind of link to the cartoons and the posters. And all of them are publicly available free of charge. We have them right now in 20 different languages, so people can use them in different backgrounds. But in terms of the next steps for treatment of mood anxiety disorder among people with substance use disorder, there are discussions in terms of using psychedelics, potential applications for different treatments, hopes with things like topiramate. So there are still discussions in terms of new medications. One other potential is using non-invasive brain stimulation technologies. And as you can imagine, there are some new advances for using this technology for both treatment of mood anxiety disorder and also substance use disorder. Those who are interested to know more about the neuroscience of addiction medicine and addiction psychiatry and how those things could show us cross overlaps with what we have in mood anxiety disorder, this is a textbook that we recently published, so you can find the textbook. And the last notes. We know that these two comorbidities are pretty frequent and prevalent to each other. They can have complex presentations in terms of the interaction between substance use disorder and mood anxiety disorders. We know that MDD is pretty undertreated in people with substance use disorder, but basically the basics of treatment is the same as we have with or without substance use disorder. So we can still kind of use the same sort of rules for treatment of MDD during substance use disorder. And we know that the process is still under study. So there are some new motivations and initiations within NIDA and in other organizations to support some new studies on comorbidities. And we are hopeful that neuroscience can inform us for treatment selection. Then we discuss about kind of naltrexone for reward during cares, acamprosate for relief during cares. These are the things that we have for alcohol use disorder. And there are similar discussions in other substance disorders right now in terms of how we can differentiate them based on their kind of different omics levels of data that we can collect. Importance of psychosocial interventions we discussed about, and also new hopes for new treatments with neuromodulation and new medications. Thank you very much for your attention. I put my kind of slides link here as well, so you can find them and you can use this slide as well. Have a nice day.